I might note, no offense to the Air Force or the Army represented here, but the statement, Amateurs Talk Strategy, Professionals, Logistics, goes to the U.S. Marine Corps. So, yeah.
Well, good morning, and I'm happy to be here. And I want to start with what I'm going to try to do is offer some general observations about how things have gone and what things we have learned. But I would, to a large degree, if I went into detail, I'd be duplicating a lot of what Paul and Bob said. So I'm going to focus a lot on what we need to be doing next over the next 6 months, assuming we have some time that can be bought. But I think I need to start with the observation that we went into this crisis with a much stronger foundation at the federal, state, and local level than we would have pre-9/11. And we're building on both the $7 billion that was invested by the federal government in the last few years around pandemic preparedness, but an equivalent amount of money, if not more, that was invested in all hazards preparedness. And they are all interrelated, even though we go from different funding streams based on what will move Congress at the moment. The truth of the matter is they are interrelated. And so we are in much better shape than we would have been 6 years ago or 8 years ago. And Trust for America's Health does an annual report that we call Ready or Not that looks at both the federal and the state response. And one of the things that we've been able to track over the years is consistent progress by the states in their level of preparedness. There's still some major gaps, and some of the gaps that we actually pointed out last year turned out to be quite legitimate, some around surveillance and also around stockpiling of antivirals. We had an indicator this year that looked at, in the 2008 report, that looked at whether states had stockpiled sufficient antivirals, and there was some criticism of that because we weren't sure if antivirals would be useful against H5N1. Well, it turns out, at least for H1N1 so far, it does seem to be working, and so that probably was a legitimate indicator. We're not out of the woods. This is still an active virus. The summer, we still don't, it's not a matter of waiting till the fall till it resumes. The virus is still out there. People are still getting sick. We don't even know yet how the summer is going to play out. So there's a lot to be vigilant about. And as both Paul and Bob said, we can't fall into this trap of flu fatigue because the immediate interest on the part of the media is gone. We certainly learned that our plans are unpredictable because are not always successful in predicting because influenza viruses are unpredictable. And we appropriately made a policy decision to stockpile H5N1 vaccine, but that stockpile is not going to do us any good in responding to the H1N1 virus. And so we are going to struggle to respond to this outbreak and to hope that the investments that the federal government has made in increasing production capacity will actually pan out. There was also, and I think one of the important lessons from this is both, as Paul mentioned earlier, is that we didn't have the lead time to prepare for the virus that our plans assumed. There was almost an ethnocentrism to our planning and the assumption that it would start somewhere else. It certainly couldn't start here, and in fact it did. And I think we need to, that obviously requires some reassessment. We also need, both WHO and the United States also needs to look at the staging of its pandemic levels, because there isn't an ability to modify based on virulence. And so that creates, from a communication standpoint, a good deal of confusion on the part of the public that a virus that is not terribly virulent, that you don't see many cases of, and yet WHO keeps raising the pandemic level. It was probably the appropriate response, but it created a little bit of communications confusion, I think. I can't agree more with what both Paul and Bob said around thinking about improving our surveillance capacity. One of the things I think we need to go back and look at is how well did the intelligence community's surveillance and the public health community's surveillance mesh? Who might have known, could we have known sooner had there been better communication there? But above all, we need to be thinking very clearly in the context of health reform about the development of health IT infrastructure and health IT capacity, that we really are clear that this is not just serving the healthcare delivery system, that it is not just being used to reduce healthcare costs, but that it has an incredibly important public health protection role as well. I think one of the things that was a tremendous success so far and is truly a result of the planning and the practicing and the exercising and some bad experiences with other outbreaks, was the quality of the communication with the public from the president on down. And I think it was effective partly because we have a president who is unbelievably articulate, but more importantly because at every stage the political people took a back seat to the public health professionals. And I think that was incredibly effective in calming the American people. At the first White House briefing, where Secretary Napolitano and Acting CDC Director Besser were essentially the lead spokespeople, it was Dr. Besser who consistently delivered the public health message. Secretary Napolitano talked about logistics and what the federal government was bringing to bear on the response, but when it came to science, when it came to public health messages, it was always a physician, it was always a public health professional who was out there. And I think that was incredibly important. And I think Dr. Besser was particularly adept at communicating what we did know and what we didn't know, and that it was okay to be making decisions based on that limited knowledge, and telegraphing from the beginning that the decisions may change as our knowledge of what was happening was changing. That's a very difficult thing to communicate effectively, and I think he did a really good job at it. And it is something that, public health, I think makes all of us nervous to be making decisions in the context of uncertainty and then having to revisit them. And I think we saw a number of the community mitigation, the school closures was, I think, one specific example where we saw that kind of adjustment. And I think that the American people understood, because in a sense it was telegraphed ahead of time that this may change based on what we learn. But I think particularly around the community mitigation guidances, we learned a lot, and we learned that we had not given sufficient attention to the social and economic consequences of those guidances, although I think a lot of those issues were raised as those guidances were being developed. I think reopening of the schools is in part driven by the fact that the virus turned out to be less virulent and that it was not perhaps the most effective containment strategy. But it was also driven, I think, by the fact that it was so socially and economically disruptive, that we had not thought through what would happen to people who had jobs that they had to go to and suddenly had to make child care arrangements. We had not thought, and that's the short-term impact. There are many other things that would evolve if we close schools for a longer period of time. It's not just about jobs. It's about where do kids get their meals when so many, especially in a recession, so many kids are dependent on both breakfast and lunch programs in schools. So these are things that we really need to go back and revisit in a pretty fundamental way. We also don't have in place, not just around things like school closures, we don't have in this country some of the social and economic support systems that frankly many European countries do have that will support people in following public health recommendations. Paul described the one story of a service worker who could not afford to stay home even though he had symptoms because he would lose his job. We are the only developed country that does not have mandatory sick leave for employees. And we have huge numbers of Americans who have absolutely no sick leave. This is not a matter of having used up their sick leave already for the year, but there simply is no paid sick leave. And they do indeed risk their economic viability, but also possibly their jobs if they take time off when they are sick. We also have a lot of people who are concerned about how they're going to pay for their health care in an emergency. This is an instance where it was relatively mild, but if antivirals are going to be effective and we are going to want to get antivirals into sick people in a hurry, then they're going to need to feel comfortable to come forward to get care. They may not have a medical home. They may not have a regular clinic to go to. And how then are we going to assure people that they won't have to pay emergency department fees? How do we reassure hospitals that they won't end up with lots of uncompensated care in a pandemic where a lot of people are hospitalized or turn to emergency departments for their care? We need to put those structures in place. Universal coverage will resolve that, but there's a significant transition period. So I think there are several things that we need to do. There's already pending legislation about mandatory sick leave. I think we could extend that even further to saying, in addition to normal mandatory sick leave, there probably needs to be some sort of public health emergency form of sick leave, so that when people are being told not just to stay home when they are sick, but part of the community mitigation guidance that the CDC has put out saying if someone in your household is sick, the entire household should stay home from work. So then you are dramatically reducing the economic viability of that household. But you're also asking people to take far more sick leave. The suggestions are up to 2 weeks. Far more sick leave than are even in the mandatory benefits legislation that is now pending in Congress. We've also been working with Congresswoman Capps and Senator Durbin on the Public Health Emergency Response Act, which would provide a federal emergency health benefit. In other words, a guarantee that during a public health emergency, the federal government would step in for the uninsured and the underinsured to guarantee that individuals would not have to hesitate to seek care because of cost, and providers would not have to worry about uncompensated care, and so to keep things moving. This was an issue that, for ideological reasons, could not be addressed in the previous administration because it was seen as the nose under the camel's tent in terms of moving toward universal coverage. In the current context, we hope that as part of whatever health reform legislation is passed, this may become perhaps a transitional benefit. Bob mentioned the dramatic economic consequences of a pandemic. We did a report looking at the various, a couple of years ago, 3 years ago now, looking at the various models for the potential economic impact of a pandemic, assuming a stable economy, and it would have been, at the time it was predicted, we predicted it would be the deepest recession since the Great Depression, but that would no longer be the case. I guess that's one way of looking at it. But it would be pulling another $600 billion out of the economy. And if you put that on top of our current economic situation, that would be pretty dramatic. And unlike other countries in the world, there are other countries who are actually thinking about creating trust funds and creating mechanisms to help out businesses to make this transition during a pandemic. A few other observations very quickly. One is, as Paul mentioned, the public health system was not truly tested. We had relatively few cases. We did not have to dispense large amounts of medicine. We didn't have to dispense lots of vaccines. We just don't know, especially in light of the budget cuts that states had faced, what would happen. And certainly the healthcare delivery system was not truly tested. But we had a hint of that. And in fact, in Texas, the health department actually put out a press release calling on people to stay away from emergency departments. In part, I think, because the emergency departments were being overwhelmed by the worried well. But I think that's a sign that even in a relatively mild outbreak, granted there were more cases in Texas and a higher level of concern, did some work in preparation for the new administration to identify just what does the public health system need overall. Just to sort of be where it ought to be in the professional judgment of lots of experts. And we needed another $20 billion. And so the $350 million that's in the House version of the supplemental to deal with the pandemic response certainly is a drop in the bucket, but is certainly an important one to be included. So what do we need to do now? I think we need to look back and see how the surveillance systems worked. I think we need to update our plans in light of the experience that we had. Most of the federal department plans have not been updated since 2006, including the one for federal workers. The Office of Personnel Management has not updated their plan since 2006, and so that plan does not even take into account all the community mitigation guidance around taking time off, staying home from work, all those things that the CDC recommended. So we need to make sure that those are up to date. And I think particularly given that we are dealing with, well, we're not supposed to say a swine flu, we need to think back to the lessons of 1976. And as we are going to be undertaking perhaps a major vaccine campaign, making sure that we have the systems in place that can track what is happening and that can do a better job of communicating with the American public about real risk and apparent risk. We certainly need to be rethinking what we have in the strategic national stockpile in terms of public health recommendations. Right now the stockpile only holds antivirals for treatment, even though the public health recommendations from the CDC say we need 109 million courses for prophylaxis. Depending on the private sector to do that will create incredible inequities in terms of access. And the very big ticket item in the short term will be the vaccine development. How do we, when is the decision point? How much will that cost? What kind of capacity do we have to deliver? And what infrastructure do we need to have surrounding that delivery in terms of being able to track vaccine from manufacturer to people's arms, both in terms of monitoring adverse reactions as well as a second dose. One last comment, which is on healthcare reform, in addition to this need for a transitional benefit, there is an opportunity in healthcare reform also to deal with some of the hospital preparedness issues. We need to assume, as part of a reformed healthcare delivery system, that the capacity of the healthcare delivery system to respond to emergencies of any kind, including a pandemic, is built into that infrastructure, and therefore is built into the reimbursement systems and the funding mechanisms that are developed in the context of health reform, so we aren't doing it through separate and unreliable funding streams. I think I'll stop there.
Thank you, Jeff.